So, good evening, everyone, and welcome to episode 2 of our webinar series, InferOperate Thorax, a Surgeon's Perspective. I'm Dr. Swativara, and I'm thrilled to be facilitating today's session. Today, we have two leading experts in the field of thoracic surgery joining us. We have Professor Dr. Severin Schmid from the University Hospital Freiburg and Dr. Rihards Mikilps from Riga East University Hospital. They'll both be sharing their unique insights and experiences on how the InferOperate Thorax AI tool has been helping with their surgical planning workflows. And Dr. Rihards brings over 10 years of independent practice in thoracic surgery, specializing in minimally invasive pulmonary resections and complex bronchoplastic procedures. He also conducts research at the University of Latvia, where he contributes to clinical and preventative medicine. And we also have Dr. Schmid, who also has over 10 years of experience and is a renowned consultant thoracic surgeon. His expertise spans in minimally invasive thoracic surgery with a special focus on robotic-assisted systems. This will be an interactive section, so please, I want to encourage all professionals who are on the webinar to join in on the conversation. So please ask your questions and we'll get them answered. Let's dive into these applications of AI in thoracic surgery and get started. So without further ado, let's welcome our first speaker. We've got Dr. Rihards Mikilps. Thank you for joining us today. I'd like to start off by just asking if you could share with us a specific case where InferOperate Thorax has impacted your surgical planning and any final outcomes of the procedure. Thank you.
Good evening, everyone. So dear colleagues, I would like to share some of my insights on 3D reconstructions, and I have to start with my current level of experience. I have some limited experience with 3D Slicer, which is free open source software. I have made some reconstructions with this software, but this is a quite time-consuming process and requires a lot of manual input, which is a main limitation for me. Moreover, I have experienced a lot of imprecisions, which have caused confusion during the surgery. And as for other 3D software, having a non-contrast CT means a much worse quality of 3D model. Currently, I'm using InferVision automated AI software. In my opinion, it has multiple advantages. Reconstruction could be done very quickly in approximately 10 minutes, regardless of the time of day. It is fairly precise and provides surgeon with many valuable tools like lesion detection, segmental margins, safety margin for tumor, possibility to switch on and off different lobes and structures. Besides, it does not require contrast enhanced CT. So now I would like to share our initial experience with InferVision software, and despite limited number of reconstructions performed, we have found it very useful and also have encountered a number of interesting anatomical variations. I will show some of them today. I will start with resection margin preoperative planning. So in many cases, we have adjusted our resection strategy according to 3D model. There are two examples on the right side of the screen. Upper picture shows initially planned right S3 segmentectomy, which was extended to S3 plus S1 segmentectomy because of 3D model. And at the bottom, there is a lesion in left S10 segment. Without 3D model, we would have performed S10 segmentectomy, but here we can see that the safety margin involves the bordering segments as well. So speaking about vascular anatomy, we have also encountered many important variations. Here you can see quite sizable aberrant interlobar vein, which was found on 3D reconstruction. Initially, I was thinking that this should be some kind of artifact, but during the surgery, we actually saw it. The fissure was fused, and we really had to dig in it to find the interlobar PA. And I was thinking during the surgery that this really might create confusion for surgeons with limited experience. So actually interlobar PA was found underneath this interlobar vein, just like in 3D model. So another example shows variation of left lower lobe segmental veins. We were going for the left S6 segmentectomy, and usually V6 is cut at the confluence of V6 and basilar vein, so quite centrally. But in this case, we found vein from segment 10 that was draining into V6. So we dissected more distal into parenchyma, and we found this small vein, and we were able to dissect it and spare it. So another example shows a normal variation of right-sided segment 2 arteries. As I previously mentioned, we were performing S3 plus S1 combined segmentectomy, and we had to spare arteries for segment 2. And according to model, there were 2 arteries for segment 2. So posterior ascending artery, so A2B, which was separate branch from PA, and the recurrent A2A, which was branching off the artery for segment 1. This was important to know. I also would like to show example of aberrant bronchial anatomy. You can see example of tracheal bronchus for right segment 1, and very strange branching pattern on the left side. So in the distal part of left main bronchus, there were 3 bronchial orifices. So first orifice was for segment B1 plus 2. Second, which was very strange, so was B3 plus B4 plus B5. And the third orifice was left lower lobe bronchus. I think most of us would like to know about this before planning any segment of upper lobe or even lobectomy. So here are my thoughts on the value of 3D model. So I think it gives us better understanding and learning of segmental anatomy. Safety margin evaluation means oncological safety. With 3D model, we have less confusion if aberrant anatomy is encountered. And having a plan means faster operation and less intraoperative complication, which means surgical safety. So now I would like to present the case, and this is rather unusual case of a 68-year-old lady who was diagnosed with oligometastatic atypical carcinoid, and she already has had systemic treatment and hepatic metastasectomy. There were 2 metastases, and more than a year later, there were no signs of progression of disease, and she was referred for resection of the pulmonary lesion, and we decided to do a lingulectomy in this case. So this is a CT scan, and here you can see the lesion in the lingular segments of the left upper lobe. And we made this reconstruction, and we found mediastinal lingular artery, which was, I think, a very important finding in this case. Not that unusual, but very important. And actually, it's more often that we see this than I thought before having these 3D reconstructions. So you can see the artery or lingula, and this is interlobar view. And usually the artery for lingula is going like this. So this is usual course of interlobar lingular artery. Okay, so this is a view from surgery. This is uniportal VATS approach, single incision in 5th intercostal space between anterior and middle axillary lines. So on inspection, no other lesions or dissemination was found in pleural cavity. So in this snapshot, we can see that the branches and structures for lower lobe are more or less like we see often, but for the left upper lobe, there is a branch to the left, and which actually is artery for segment 1+2, and we can see that there is no artery for lingula in the fissure. So if we imagine a situation where visibility is limited by partially fused fissure or adhesions, this artery could be mistakenly identified as a lingular artery, but it's actually artery for segment 1+2. So now you can see surgical video, and the lingular vein is dissected. And divided. So now we have access to lingular bronchus, and there is this lingular artery behind the bronchus, and now the bronchus is separated from the artery. You can see artery there, and actually, if the fissure is fused and the surgeon would go for in different case for apical trisegmentectomy without knowing this, I think the lingula could be left without any arterial vessels. So now the bronchus is dissected and divided. And after division of the bronchus, you can see this mediastinal lingular artery is dissected, and we decided to occlude it with polymer clips. The artery is divided. So now you can see interlobar view and the stumps. So now the ICG was injected, and there was clear delineation of intersegmental plane, which demonstrates patency of the arteries to remaining segments. And so this demarcation line was used to resect parenchyma. The specimen was removed, and this is after the segmentectomy is completed. This is a view from the fissure. So these are the left lower lobe segments and the stumps and the remaining structures. So, and speaking about postoperative period, so this lady had an eventful postoperative period, and the chest tube was removed on the second postoperative day. On the final pathology, the grade 2 neuroendocrine tumor was found, actually atypical carcinoid, and given the unusual clinical picture, the pathologist was asked to compare the specimens from pulmonary tumor and hepatic lesions, and in both cases the tumor cells were the same, and she was discussed at MDT. for the following treatment. So thank you for your attention. I will be happy to answer any questions. If you are interested in thoracic surgical videos, you can find more interesting cases on my YouTube channel. So thank you. Are there any questions?
Thank you, Dr. Rihards. That was excellent. Really fascinating stuff. We don't have any questions from the Q&A at the moment, but I guess one question from my side is, how would you rate the accuracy and the reliability of the 3D reconstructions for making kind of, these really important decisions?
Yeah, I think it's fairly precise. Of course, there might be. I have seen some small imprecisions, but these are usually these are not clinically significant, and by just by looking at the branching pattern, sometimes you can really see that this is some kind of artifact. But these are I think this is seen less than in other 3D models. So I think it's fairly precise.
That's great, thank you. We don't have any questions at the moment, so I think now is a good time for us to move on to our second case, and then we can have some more questions at the end. So please, from the audience, if you do have questions, just type them up and we'll get them answered. But now moving on to Dr. Schmid. So as someone who specializes in robotic-assisted surgery, how has InferOperate Thorax integrated into your workflow, and kind of how do you see it complementing robotic systems in thoracic surgery?
Well, hello, everyone. Thank you very much for the introduction. Thank you very much for the first case presentation and also the nice introduction to the general system and the ecosystem of the software. I'll be sharing my screen and be presenting another case. I hope you can see the screen now.
Yes,
it should be
see.
Full screen. Thank you very much. All right. So I've been doing segmentectomies as well as complex segmentectomies for a couple of years now, but I've just been starting to use 3D reconstruction software. We had it available a couple of years ago. We tried it out, didn't really thought it was necessary, but now that I've been using it more and more, I really find two things. One is that it helps me with some issues we've been having with segmentectomies, and on the other side, there are also issues coming up that we didn't know we could have, and a lot of interesting insights that we're gaining from this experience. Secondly, we're trying to, or at least I'm trying to do most segmentectomies with the robots, as I think it's a perfect match with the 3D reconstruction and the robotic system, as hopefully we will see in the video that I'll be showing. These are my conflicts of interest. I'm receiving speaker fees for today's presentation, but I'm trying to stay as objective as possible. And also I'm an instructor for intuitive surgical for robotic systems. So this would be related to the content of today's presentation. I'll be presenting one case, which is robotic S12 resection on the right side for small non-small cell lung cancer. It's pretty straightforward case regarding the oncologic setting. So it's a 51-year-old patient, female patient with a growing FDG-avid lung nodule in the right upper lobe. There was a fair amount of smoking history, 20 PEC years. Nothing really from the major medical problems, but and also normal lung function. So you see the CT scan on the right side, and then you should find the nodule in the right upper lobe, coming up right about now, just in between the central structures, so relatively central. You could try to take a biopsy, but I would say, given the smoking history, the growing nodule, and the FDG avidity, there's such a high probability of malignancy that even in the case of negative biopsy, you would go for resection. And in this case, it would be a primary segmentectomy. So we jump right into the 3D reconstruction, which you should be seeing right about now. This is the first view that you see when you use the software. The different modes. I'm not going to go into details, but for the most cases, at least for segmentectomies, there's the lobes mode, in which you can turn on and off or show and not show different aspects of the different lobes. So we're in the right upper lobe, so we're going to take out all the other structures from the other lobes that we don't need at this point. I usually leave in the main blood vessels and the main bronchi, as they give me some idea as to where to look. And then usually I start by looking at the bronchi, as they have the most reliable anatomy. The variability in the vessels is usually higher. So we take out the arteries and the veins, and this is what we look at this point.
Sorry to interrupt, Dr. Schmid. I think you might be on another screen, but we're still on the PPT.
Okay. Let's try this again. Is this better?
Yeah, we can see it now.
You see the software now? Okay. So I'm just going to show show what it looked like before with the arteries and the veins. So this was the view when I took out all the other lobes. This is just the artery, vein, and bronchi of the right upper lobe. So then we take out the arteries and the veins. As I said, as the bronchial anatomy is usually the most reliable, and this is what we look at this point. Then we can show all the segments of the right upper lobe. S1, S2 subsegments is also possible, but this is not interesting for today's case. And so the first thing, at least what would not be obvious to me when I look at the CT scan, is that the nodule is not located directly on the center of segment 1, but right at the border of segment 1 and segment 2. So also, if you show the margin, that would be 2 centimeters for this case, or the size of the nodule, which is around 1.6, 1.8 centimeters. This entails includes the segment 2. So you can't just do a segment 1 resection, but you also have to do a segment 1 and segment 2 resection. So this is the first insight we gain from the 3D reconstruction that would, at least to me, not be obvious initially. The bronchial anatomy in this case as well is relatively straightforward. So we have the S1 or the B1, the B2, and the B3 going straight into the different segments. So this is nothing unexpected, everything as usual. So we can go ahead with the arteries, which I will show next. And here it gets more interesting. I think Dr. Mikkelbs has shown a similar case. When you follow the arteries, then you have the truncus anterior, which usually divides into an A1 and an A3, and you usually have a recurrent A2. In this case, it's different. So we have the upper part of the truncus anterior, which has or provides the A1, but also from the upper part of the truncus anterior is branching off the artery to segment 2. So we have both arteries branching off the upper part of the truncus anterior, and furthermore, we do not have a recurrent A2. So we don't have to look into the fissure. We know, or we don't have to look for the A2 in the fissure, and we know that by dividing the upper part of the truncus anterior, both arteries are taken. In this case, this is an advantage because we want to resect S1 and S2, so this is pretty straightforward. And lastly, we show the veins. Here, I also like to go from the hilum to just follow the veins as they usually would go. Here we see a V3 going anteriorly to the S3, which is draining the S3. So we leave that alone. We have to protect it and not divide it. And also we see an analogy to the artery, we have a large truncus draining S1 and S2. So the vein draining both segments with this large vein in the upper part of the upper lobe vein. Lastly, what we would expect would be a posterior vein going to the S2, which is not the case in this patient. So we have a posterior vein, but it's mostly draining the S3. And there's only small branches going to the S2, so we want to leave this alone. There are two options. Either one option that Dr. Mikilps has already been shown. You can either go deep into the parenchyma and follow the vein and just take the little branch that is going to the S2, or you just take the vein with the intersegmental plane, which we've done in this case, which is usually the easiest way to go. The more important part is to protect the vein that is going to the S3, so there's no venous congestion in this part. So this is seemingly a relatively straightforward case. You see my presentation again now?
Yes.
Okay, perfect.
Yes.
Seemingly is pretty straightforward case, but there's a couple of things that we've learned that are really important, as to my opinion. The nodule is not in the center of one segment, but right in the border in between the segments 1 and 2. The A2 is originating from the truncus anterior, and also there's no recurrent artery to the posterior segment, for which we would look in the fissure. Venous drainage is the posterior vein is mostly draining into or mostly draining S3, so we don't want to resect that. And the bronchial anatomy has no anomaly, so we don't have anything to pay attention here. So this is the video to the case, which I hope you can see. So in the upper part, you see the venous branch going to S1 and S2, which we're dividing. And you can also see the posterior vein, which we've seen, which is mostly draining V3, as well as the basal part of the vein, which is also going into V3. So we preserve those and divide the upper branches. And here you see the truncus anterior with the upper part. So you can see a small division, which really doesn't matter in this case, if we would, or a small branching. And it really doesn't matter in this case because we want to take both segments, which we're doing right now. And after that, we can apply the ICG because we're sure about having divided everything that is supplying S1 and S2. And as you can see, there's near perfect delineation of the two segments, which we're marking, as you've seen in the video before, for later resection. So we just have to follow the dots. So we're marking the intersegmental planes and going to the hilum in the front and to the hilum in the back, which you'll see in just a few seconds. And then we'll take in the bronchi, and first we'll go take the B2. And here, just in the fissure, you can see that little venous branch, which we've seen in the 3D reconstruction software, which is going to S2, which we've not taken separately. You could do that. It's not really necessary, but the most important part is as you don't take the posterior vein in this case too far or too proximally, as you would affect the venous drainage of the segment 3. So here you can see the artery to the A3 or the A3. You can see the B1 being divided, which is pretty straightforward, and also the preserved veins to the segment 3. And now we're taking the two segments S1, S2 along the previously marked intersegmental planes. Here we're taking this little venous branch with us. We see that the hilum is included. And it's really nice because everything just falls into place. Before using the software, the 3D reconstruction, there was always some cases where there would be some structures coming up about which we would be unsure. The intersegmental planes weren't always super clear. Sometimes we wouldn't divide all the arterial branches that are supplying the different segments. So everything falls into place here, and you can see this the intersegmental planes is coming along nicely with the hilum, and everything is included. And you really don't need any marking of your nodules, as if you do this correctly, the nodules should always be within the resection or within the specimen. So this is taken off. The bronchus is still there, still intact. You can see the A3 still intact, and the veins posteriorly and anteriorly also intact and preserved. So this is the case. Here I just put the delineation of the ICG side by side with the preoperative view, the preoperative view of the different segments, and you can see a near perfect alignment. And this is usually the case, that the ICG, which you give intraoperatively, will perfectly align with the preoperatively planned segments. So this is really nice. And as I said, everything just falls into place. And this is a lot of fun and really just a nice case to be done. So case was, the postoperative course was uneventful. The chest tube was removed on postoperative day 1. As expected, it was a 1.7 centimeter long adenocarcinoma. There were no lymph node metastases. It was an R0 resection. Resection margin was adequate with 1.8 centimeters, plus the staple line, as I think everywhere else, the staple line is taken off and then it's measured. So this should be a nice resection margin. And this is really what in my opinion, what the post-op x-ray should look like. There's no venous congestion. Really, you can't really see that something's taken off, but this is the case. If everything's done correctly, the intersegmental planes are taken correctly, the veins are preserved. And so I think this is just the perfect match of the different tools that we have, the technology that we have, which is to be used in these cases. Thank you very much.
That's great. It's really interesting to hear about your initial experiences with the technology and kind of how that evolution has happened. We do have a question in the Q&A. This can actually be for both surgeons. So we have a question from Evars Berzins. They're asking, so when you're preparing the 3D models, is that done by yourself or is that with your residents?
I'm just going to start because it's pretty straightforward. You don't have to do anything. You just upload the DICOM data, which takes about 2 minutes. And then the reconstruction is done by the AI. And so you upload the data. It takes about 5 to 10 minutes for the reconstruction to be done. Meanwhile, you can have a coffee and then you can just look at the pictures and everything's prepared. So there's really nothing you have to do.
Yeah, I have to agree with Professor Schmid. It's pretty straightforward, and the uploading is the only manual input, and then you can play with 3D reconstruction 10 or 15 minutes later. It's that easy.
Brilliant. Yeah, exactly. So it's not like you need to do like an ROI on any of the CT images or anything. It's all automatic. So both excellent cases that we've had presented. We do have another question from kind of InfoVision side, just to think a little bit about the future and some of the challenges that have been involved. So again, feel free to kind of both of you to think about your own answers. And what have been the main challenges in kind of wider adoption of this technology in surgery? How have you seen the landscape change?
I think this is. I think this 3D modeling just opens another room for surgeon. It's you know, you are operating in you are thinking in completely different way because you have this 3D model, and with each operation you are going much deeper in segmental anatomy, and you know, you always you can look in the book, but it's never the same. So it's you have to know about the most common variations and the rare ones. It's I think it's just a matter of time, and I think 3D models will be adopted across the world.
Yeah, I have to agree. It's a completely different mindset using the 3D models. I think the biggest reason, or there's two reasons in my opinion. One is cost, or why the software is not used widely or widely applied. One is cost. So in Germany, we have just a certain amount of money which we'll get reimbursed for every patient. So this using this software is also a cost that we have to include in these cases. But the more important part, I think, is the awareness or the recognition of the complexity of the anatomy, particularly what I was trying to show with the different vessels and what impact it has if you're not recognizing the anatomical variations, particularly venous drainage. It's super important. So if you leave in a part of the lung, but it's not sufficiently drained, or the other way around, you leave something in as a sequestration, which is not, or for which you have cut certain parts, for which you've cut the bronchus, then the segmentectomy doesn't really make that much sense. So there's been some criticism about doing segmentectomies. There wouldn't be much of an advantage because lung function preservation is not as high as we would expect. I think some of the part why this is the case is that it's not done correctly, and it's only done 100% correctly if you use these tools. There might be some colleagues that are super good with CT scans and seeing everything. I would claim I have some experience with CT scans and trying to find the anatomy, but for me, it would not be possible to do it the same way. And also to just recognize the segments, the size of the segments. There's a huge variability as to the configuration of the segments and the size of the segments. And all these things are important to do correct segmentectomies and to have all the advantages of not taking out the lobe, of doing sub-segment or to doing sublobar resections to preserve lung function. And if you're not doing it this way, then you might as well just take out the lobe, I think.
Okay. I guess we're coming towards the end of the webinar series. I've just got a final question for you both. What advice would you give to kind of surgeons who are on the fence still, so they haven't started using a 3D reconstruction tool, they're thinking about it? What advice would you give them?
My advice would be just start to try it and to play with it, and I think the first cases for which we done these 3D reconstructions were lobectomy cases, and we were just checking is this really the case? Is this the case? You can see everything on 3D model. Is it the same during the surgery? And the first cases were lobectomy cases actually, but for segmentectomy, it's amazing how fast you are improving with the understanding of the 3D anatomy of the each segment. It's really amazing.
Yeah, I mostly agree. Maybe another thing that you could do is just look at some older cases that you were struggling with, and just put them through the software and look at what's been the issue, maybe, and maybe get an idea of what has been unexpected, or what anatomical variation was there and you didn't recognize at the time. And I think if, as Dr. Mikkelbs said, if you just play around with it a little bit of the cases you've done or the cases you've been planning to do, then I think you find a lot of things that you didn't know before, and you learn a lot of things. And I think the learning curve is relatively steep, and the outcomes will improve. I'm pretty sure of that.
That's great. Some excellent advice there. Well, thank you both very much for your time this evening. And thank you everyone for joining and kind of asking questions. We will send out a survey as well, so please feel free to kind of note down any questions on there as well. We're happy to answer those. And if you are interested in trialing out a 3D reconstruction tool, so our InferOperate Thorax, just get in touch with one of our team and we'd be happy to kind of provide a demonstration and trial some cases for you. That would be more than happy to do that. Thank you again, both surgeons, for your time this evening. It's been a pleasure and really enjoyable to hear about your interesting cases. Thank you, and have a great evening, everyone, and happy holidays before all the festivities next week.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye now.